We need to ask everyone who subscribes to the show, please listen to the podcast when it drops and give us a little discussion about it. It really helps. Also, we want to thank our sponsor, Hydralyte. Go to the banner on DrDrew.com for details. If you click on the DrDrew.com Hydralyte banner, we have a 30% discount for those particular vendors on the Amazon site. Also, thanks goes out to alliant.edu for those support. A great program, great school. Check them out if you're thinking about training in psychology or you're looking for care. Great place to go. I'll tell you more during the break. Support our sponsors so we can bring you more weekly infusions. Hey, Dr. Drew here, and this is just a reminder that the discussions here are not a substitute for medical care or medical evaluation. This is purely for entertainment and education. We hope you learned something, but see your doctor, get proper medical care. All right, it is fall and your immune system is about to get tested, everybody. Not only does the changing weather mark the start of cold and flu season, it's also back to school time when kids become walking petri dishes. While catching something may be inevitable, there is no excuse for letting yourself get dehydrated in the process. So when you're wiped out with cold or flu, the first piece of advice always to drink plenty of fluids, but we seem to forget that. Now, once you've started feeling dehydrated, it's already too late for water or sports drinks. Rapid rehydration requires the proper balance of sodium, glucose, and water, and nothing gives this like Hydralyte. Hydralyte's formulation is based on established, proven science, and it is the simply best rehydration product I've found in this country. Hydralyte comes in great flavors, orange, berry, lemonade, and it's available in a pre-mixed drink, powder, or what I prefer, those effervescence tablets. You just drop in a glass of water or a bottle of water, off you go. It's like your own portable IV, but you can do it enterally. Compared to sports drinks, Hydralyte delivers up to 4 times the electrolytes with 75% less sugar. Hydralyte solutions are appropriate for all ages, and each bottle or package includes easy-to-use, easy-to-follow instructions. You can find Hydralyte at Rite Aid or online at Amazon.com. And for a limited time, our listeners can save 30% on Hydralyte. Just click the banner on our site, DrDrew.com, 30% off. Great deal. Do it.
Welcome to Weekly Infusion with Dr. Drew Pinsky and Dr. Bruce Heischober. Weekly Infusion addresses medically related topics. It's in the know, entertaining, and everything you want to know about health and medicine. Now may I present to you the very wonderful Dr. Drew and Dr. Bruce.
Hey, welcome to another Weekly Infusion. Dr. Bruce, how are you, sir?
Excited today.
Fantastic. Very excited. We have Dr. Henry Friedman, academic adult pediatric neuro-oncologist. He leads the Preston Robert Tisch Brain Tumor Center at Duke University. Research focuses on treatment of adults and children with brain and spinal cord tumors. Dr. Friedman, welcome to the program.
Thank you so much. I'm deputy director. There is a director, but I'm honored to be considered even at that level.
A big part of it, a big part of the program. And
that'd be good.
Is your background medical oncology, neurology, or neurosurgery, or some combo therein?
None of them.
None of them.
It turns out that I trained in pediatrics with Frank Oski, who's a big-time ped hematologist at Upstate Medical University. Then I did ped hemonc. Then I came down to Duke to do more ped hemonc. Then began to focus in neuro-oncology, built a program in pediatric neuro-oncology, and in '99 hired somebody to do that and switched over to adults because it was so difficult to get anything from drug companies to work with children. And at least with adults, I had the chance to do it, and then there could be a trickle-down to kids. So I'm a pediatric oncologist who learned neuro-oncology on the job, and now I do only adult neuro-oncology.
I love that. That's how I learned addiction medicine was on the job. Trust me. It takes a little longer, but you get your, it's a very self-motivating kind of experience. Yeah. Where should we start this conversation? I guess what's interesting to me is what is exciting you most right now.
Well, we're doing a lot of different things, but probably the thing that is the most exciting to us in neuro-oncology and maybe in all of cancer at Duke is the use of the modified polio virus, which we're using initially to treat glioblastoma, but is going to expand very quickly into other solid tumors because the modified polio virus binds to a receptor, CD155, which is on all solid tumors except Burkitt's lymphoma. And so, although we're starting with glioblastoma, we will open in the next 3 to 4 months, or people who work with us will open a breast cancer study and a melanoma study. But in reality, this construct can be used to treat virtually all solid tumors and we're just going to expand it as we just get more trials in place.
So let's go down into the biology of this a little bit. The CD1 receptor is how
CD155, right?
But CD1s generally, the 155 is a specific CD1, right?
Correct.
And the CD1 generally is how T cells identify cell surfaces, right? Is that correct?
That'd be correct.
And identify self versus other kinds of, where that process is initiated. Is that about the way to say it?
And T cells are lymphocytes, which are white blood cells.
White blood cells, which attack
that is
foreign things. So, and on the T cell, there's another receptor. There's the CDL receptor, right?
You're beginning to go outside my area of expertise. I'm not really the immunologist of our program.
There's a CDL one.
I can tell you how this works, but I can't get into the nitty-gritty of the immunotherapy or the
Okay, I'm going to have you describe it because I don't.
A little bit beyond me.
I'm going to have you describe it because I don't know it. But the reason I was going down this path was it's fascinating to me how everybody is zeroing in on this particular biochemistry. I work a lot in prostate cancer. And this is where a lot of the stuff is being directed now, either the CDL receptor or the CD1 receptor, and it's just how cancers are able to grow without the immune system attacking them is finally becoming an area for therapeutic intervention, which is spectacular. I mean, massive. It's a huge deal. But I'm sure you'd agree with me on that. But explain to us how the vaccine does its thing.
Okay, so when we give it's a Sabin vaccine. There used to be a Salk and a Sabin vaccine. Then there were some problems with the Sabin vaccine because it's a live attenuated virus, and people could actually they shed it in their stool, and you wound up potentially infecting older people where their immunity had waned, or people who were on chemotherapy, or people who were immunodeficient, and give them polio. So basically, now everybody uses the Salk vaccine. But this modified Sabin vaccine was engineered by a scientist, Matthias Gromeier, in 1994, while he was at Stony Brook, to add a rhinovirus construct at the internal ribosome entry site.
Okay, make it so the average person can understand that.
What it means is that this vaccine, or this modified poliovirus, can bind to neuronal cells, but it can't replicate, it can't do any damage, whereas when it binds to tumor cells, what it's doing is it's lysing the tumor cells. But that's not really the major picture. So that it's an oncolytic virus, it binds to tumor cells, and it then lyses some of the tumor cells. The lysis basically releases a sort of a tumor RNA gamish, and it also infects dendritic cells. But unlike other viruses, it doesn't kill dendritic cells. And dendritic cells are the cells that present an antigen to the T cells. It stimulates the dendritic cells and gets an interferon-1 response. And what that means is it's the only oncolytic virus known to man which not only is lysing tumor cells, but more importantly is increasing the actions of the dendritic cells. So that the dendritic cells pick up these dying tumor cell antigens and basically present it to T cells, and now all of a sudden you've got a systemic response. So you don't really get the big bang from the lysing of the cells, you get the big bang from the immune response that this generates. What that means is that if you're dealing with cancers like a GBM, where we know it's all over the brain at diagnosis, you may see a lump, but it's microscopically everywhere. You infuse it into the tumor, and you start a systemic response that can really treat the cells everywhere in the brain. If you're dealing with metastatic breast, metastatic colon, metastatic prostate, metastatic anything, you don't have to treat every lesion. You just have to treat enough of a lesion to get this systemic response going, and you've fired up the immune system in an extraordinarily efficient way.
Okay,
so the first trial was 61 patients, phase 1, dose escalation, and ultimately we learned that the philosophy of oncology, which you know from prostate is more is better, doesn't work in immunotherapy. You don't need it. We had to go from dose level 1 up to 5, down to dose level -2, and settled for -1, and that's the dose level that we're moving forward with. We got breakthrough designation from the FDA, which means a one-arm study and very, very careful attention from the FDA, but we're not ready to do it yet in the registration trial. So we're running two separate trials. We're running a 4-institution trial, or it's about to go in a 4-institution. We started at Duke, which is giving the modified poliovirus and 1 dose of CCNU. Why? Because CCNU, that 1 dose, brings down so-called Tregs, cells that impair the immune system, and we're getting better activity in patients. And the other is going to be, as you'd expect, the poliovirus therapy with a checkpoint inhibitor, which is another way to boost the immune system. And whichever looks like it's the most promising, that's going to go to a registration trial.
All right.
And so for us, we have patients now. When you have a recurrent GBM, median survival is 7.5, 8 months. We've got patients out more than one, over 5 years, surviving with this. And we've never seen anything like this. And so for us, for GBM, it's extraordinarily exciting, and we want to expand it into other solid tumors.
I have a million questions.
Yeah, me too.
I have a million questions. And I want to try to break it down in a way I think the average person could not quite follow you. So I want to make sure that we reiterate stuff in ways that are understandable. GBM is glioblastoma multiforme. So just, it's a common brain tumor, and that's what we're talking about here.
Malignant.
All of them are all bad. Let's go back to CD152. I'm going to go down this cascade again, but it's in slow motion now. I didn't hear where the CD155 came into that. Is that the ribosome? Is that what gets the
CD155 is the receptor on tumor cells, or even on normal cells, that the modified virus is actually binding to.
Binding
it's the receptor.
And then it's brought in, it goes to the ribosome, is that what you said?
No, what I said was that they put in at the ribosomal entry site, a rhinovirus, which makes it impossible for this to replicate in normal cells. So in normal cells, because when you think of polio, you think of attacking, spinal neuron cells and kids and iron lungs and all sorts of horrible things. It doesn't do that. It produces no neurological side effects. It can't replicate in normal neurons, but it does replicate and lyse tumor cells.
So the rhinovirus is what gives it the power to replicate in the tumor cells.
No, it's not the rhinovirus that gives it the power. It's the rhinovirus which is protecting. It's this combination virus, because of the rhinovirus ribosomal construct added to it, prevents it from doing any damage to normal cells.
Okay, got it.
Okay. So the rhinovirus is sort of a common cold virus, right?
Yes,
yeah.
And
Absolutely.
how
I've got one now, right now.
Yes.
I have a damn rhinovirus.
But there are over 100 viruses that can cause a cold syndrome. How did you pick a rhinovirus to modify the polio virus?
And how that
I didn't do it. The person that you're going to need to interview for that is Matthias Gromeier, who did all this work at Stony Brook in 94, was published, came to Duke, and continued to develop this with Darrell Bigner, who's the director of our center, and ultimately worked with the FDA, who basically initially said, let me hear this right. You're going to give a modified polio virus to patients. It's going to mutate, shed in the stool, which is what polio does, and you're going to produce a pandemic, and the world's going to end.
Yeah,
and he said, none of that's going to happen. So it doesn't shed in the stool. It doesn't replicate. It doesn't mutate. It doesn't do anything. And the FDA finally gave us the green light to begin patients, and the first patient was treated in 2012. So that means it was 18 years from the construct to first patient. Wow. That's a long time.
That is a long
time. But that's typical.
Now I want to go to the what you call the RNA gamish.
Right.
So the dendritic cells are pulling together the gamish, right, and presenting it to the T cells.
They are basically reacting with the damaged tumor cells, RNA. And what is happening is that they are presenting this as a foreign antigen to T cells.
My question is it a single foreign antigen they're identifying, or are they identifying all kinds of foreign antigens, and so multiple T cell populations are developing?
I believe it's a single T cell population, that is basically being presented by the dendritic cells.
Got it.
And that population of turned on T cells is what then produces the immune response.
Got it. And then you said CCNU, which is chemotherapeutic agent. Why did you pick that?
Yeah, we made this funny discovery. We had patients who had failed chemotherapy, so we gave them the virus. They responded. Some failed. And so we took a couple of them and gave them a single dose of CCNU, which is also called lomustine, which is a separate story we should probably talk about in a minute. And basically, it produced unprecedented shrinkage of the tumor. We were overwhelmed with the kind of responses we were getting. So because of that, we basically thought, all right, and proved it, that we're decreasing so-called Tregs, cells that suppress the immune system. So we said, well, if it's doing that, then why don't we give it in combination with the viral therapy before the virus therapy ever fails? So we're giving polio, and then 8 weeks later, they get 1 dose of CCNU. It's a randomized phase 2 study. It's not comparable. We're just looking to see comparative. We're looking to see if there's a signal in either arm. Half the patients get polio, half get patients get polio and 1 dose of CCNU. We're looking to see which like it might be a better outcome for those patients.
And then in the when the tumors stop responding, are they getting a resistance, or is it just it's gone as far as it can go and just starts growing again?
Well, it's not clear yet. We're getting some tumor samples to see in those patients, but we really don't have the studies done yet. I mean, one of the things you'd like to know is, did they lose the receptor?
Right.
Have they developed some mechanism of resistance to the virus-induced immunotherapy?
Exactly.
We don't have those answers yet, but those are questions that we're certainly asking, because you'd like to know why it doesn't work. Right now, we're getting about 20% survival at 3 years.
That's
which,
amazing.
again, when the median survival is 7 to 8 months, is an extraordinary observation, but it's not good enough for us. We want to see if we can do better before we take it to registration.
Now, you and I have a friend, Brian,
Right.
Paul Brian from Corolla Show. Was it a
He has
GBM?
glioma.
Just straight glioma.
Yeah.
He had a midbrain glioma, and they put him on Avastin. Are you guys using that in addition?
We are the people, the initial studies on Avastin, you're throwing me softballs. The original studies on Avastin in brain tumors were done at Duke by some of my faculty, and I was last author on that. And we took that information and went to Genentech. It's a more complicated story than that. It's an interesting story. But ultimately, I did a study where I was PI called the Brain Study that basically treated patients with recurrent GBM with either Avastin or Avastin and irinotecan. Both arms showed activity. And on the basis of that and a unanimous vote by ODAC, it was approved for recurrent GBM. We are indeed using Avastin, but we're using it in a different way. Sometimes you get a amazingly robust immune response. You get inflammatory changes, edema, that really don't represent tumor, but that represent a very robust immune system. Initially, fighting the tumor. Initially, we were using steroids, but corticosteroids, 1, can blunt the immune system, and 2, they produce a lot of side effects. So we started using Avastin at a smaller dose than is conventionally used to fight tumors, 7.5 milligrams, and we're giving it every 2 to 3 weeks, and we give 3 doses. And we've found that we can diminish, if not eliminate, the need for steroid support, and the patients do far better. So we're not using it right up front, but we use it in those patients where it looks like we've got an immune response that we really need to try to chill down, and Avastin is the perfect agent for that.
And this is GBM again we're talking about in your treatment.
This is all GBM right now.
You also mentioned checkpoint inhibitors. What's going on there? And explain to people what that is.
A checkpoint inhibitor, and there's a number of them. Nivolumab is one by BMS. Keytruda is one by Merck. Are agents that basically block pathways that blunt the immune system. So in effect, the immune system is upregulated. It becomes more active. So people are thinking about, well, maybe that's a good thing to give with vaccines. So we are about to start work in patients that we've already shown in the animal model using an anti-PD-1 is unequivocally increasing the benefit of the poliovirus poliovirus technique or poliovirus therapy. So because it's worked so well in the animal model, we're eager to take it into the patients, and we will be doing that.
Okay, I don't want to get into any
very excited.
So I'm John McCain right now.
Oh yeah.
What do you? It's just
What's he got? I don't know what he has.
Doesn't he have a glioblastoma?
Glioblastoma.
High grade.
All right.
Right. So
okay. So the only things I'm willing to talk about
Right.
him, I have no privileged information.
no.
So the only thing I'm willing to nor capable of talking about is what has been put into the public domain.
Yes.
And he has a glioblastoma. What was put into the public domain was that it was a gross total resection, was treated, to my knowledge, per what was, again, out there, I have no privileged information, with, I assume, radiation and temozolomide, the standard of care, and I have no idea what's happened after he had his first post-radiation Temodar MRI, and if it has not come back, then the standard approach would be to continue with monthly cycles of Temodar or temozolomide 5 days every 28 days.
What's temozolomide?
Temozolomide.
What is it? What's the generic for that?
Temodar.
Okay.
Temozolomide is
okay,
generic.
Okay.
Temodar is, or Temodar in this country, Temodal in Europe. I don't know why it's
and so if somebody
European name.
presents with a peripheral GBM, is that the way to do it? Then go to your therapies, or would you suggest people consider starting with the kinds of therapies you're doing?
The poliovirus therapy is only for recurrent disease.
Recurrent disease.
That's how we're starting.
Okay.
So you wouldn't get it for a newly diagnosed tumor.
Right. Okay. But maybe let me ask the question a little differently. Will the day come where this will be initial first-line therapy, do you suspect?
It could very well become first-line therapy, but it's a little tricky because you would have to give it before you did a tumor resection. Maybe you did a tumor biopsy, because you have to have tumor that has to be lysed to be able to turn the whole process on. So if you're newly diagnosed and you get a resection, and it's a gross total, and there's nothing to inject the virus into, you really have undercut the ability of this therapy to work. So we've talked about what we're going to do for newly diagnosed. We really haven't focused on it because we're so many years away from that. Mm-hmm. But it would have to be done in a way where there's tumor that you can actually inject.
Now, we're again focusing on stuff that's in the press. Melanoma, the Jimmy Carter melanomas in the press. Would you have a specific recommendation on, or at least for the kind of treatment? Would you recommend that he got the treatment he got, and can you explain how that works?
Well, I don't know very much about what he got, except that I know he got a checkpoint inhibitor.
Yeah.
And I know that checkpoint inhibitors in melanoma are really redefining the field.
Yes.
And so I think that he got something that increased the immune system, and obviously has had a very successful therapy for him. Unfortunately, checkpoint inhibitors alone in the GBM world have not proved to be nearly the same kind of intervention as they have in things like melanoma or other tumors. Checkpoint inhibitors alone aren't going to do the job. They're going to have to be combined with other things, whether it be a different vaccine or the modified polio virus. It's going to have to be something more than just a checkpoint inhibitor.
I'm just trying to think of things that are in the press before we go back down our medical rabbit hole again. But are the kinds or types of brain tumors changing? The quality of what you see is the incidence and epidemiology changing at all? People always want to blame, cell phones and whatnot.
There's only one. There's only one proven. I'm involved in this a lot because there's always medical legal cases where somebody said they got a brain tumor because of a spill of vinyl chloride, or they got this or they got that.
Yeah.
The only known environmental etiology connected to brain tumors is ionizing radiation. So if you got lucky and you bought this incredible property and built a beautiful condo a week before Fukushima went down the tubes, or 3 Mile Island, or Chernobyl, or you happen to be one of the unlucky children who got the misguided therapy that was supposed to treat cradle cap, tinea capitis, with electron beam radiotherapy,
sure,
which is a true story, and they got brain tumors. Or children with acute lymphocytic leukemia who had to get whole brain radiotherapy as part of their treatment, which cured their leukemia. They're getting brain tumors now.
Which ones?
Radiation is the only known etiology.
What
cell phones, that's just nonsense.
What are the kids getting? Because that's a lot of those kids.
GBMs,
yeah. Is that the most common brain tumor?
No. There are 20,000 primary brain tumors in the country each year. There are 20,000 benign brain tumors that are primary each year. And if you look at the incidence of GBM, of that 40,000 total, or 20,000 malignant, GBM would be the most common one, 13,000 a year. But if you really look at brain tumors, and our program does not really specialize in metastatic tumors, although there are other people who do, there's probably a couple of 100,000 metastatic tumors, things that have come from lung cancer, melanoma, colorectal cancer, prostate cancer, renal carcinoma. Those are bad offenders to give you brain mets. But
testicular.
That's far more common.
Testicular goes up there too.
Mm-hmm.
That's what happened to Lance Armstrong. Testicular.
Absolutely.
I would have thought that was more. It's pretty common. You see an awful lot of that stuff. Particularly colorectal.
200,000 is a lot of cases.
Yeah, I guess that's true.
For metastatic brain. Primary brain, not so much. So the only reason that a pharmaceutical company really may focus on that is either they have a very specific interest in the tumor, or B, the bar is so low, and it's not like you have to do spectacular to get something approved, because nothing is really all that phenomenal in GBM. So it's an easier path to approval. Once you get a drug that you're selling, it then becomes easier with a revenue stream for companies to start looking at the big money makers, which are the more common cancers, breast, lung, prostate, etc.
And when you talk about the benign tumors, are you including vascular tumors, or are we just talking about meningiomas, that sort of thing?
I'm talking about low-grade glioma. I'm talking about pituitary tumors. I'm talking about meningiomas, which can be malignant. I'm talking about a whole spectrum of different kinds of tumors. There's lots of
AVMs and all that kind of stuff. Or is that
no, not AVMs. AVMs are not brain tumors. No, I don't consider vascular malformations or things like that, or aneurysms in the brain tumor category.
How about cysts? How about cysts, arachnoid cysts, that kind of thing? Is that going your
arachnoid cysts are not brain tumors, and they're
but some of these
delightful to diagnose. Because once you diagnose it, you basically tell the patient you're going to be fine.
But some of these,
listen to this story. Our son fell off a bed, age 1. Lost all his vital signs, went to the ER, and they look at me and they go, "Did your child have any kind of traumatic birth or anything?" And they go, no, this has been perfectly healthy. They go, "Oh, it must be an artifact. And I go, let me see the scan. He has this huge defect in his cerebellum that was pushing the fourth. I said, I don't need an artifact that pushes the fourth ventricle over the right side of the brain. Are you kidding me? It was like, and it was a big old arachnoid cyst that they then fenestrated. And then he got something I'd never seen in my training, posterior fossa syndrome, which was delightful.
Yes. Cerebellum mutism, absolutely.
Delightful.
Wow.
And now he's in law school.
Yeah.
So anyway, so
that was in Vegas too, wasn't it? Yeah. So now what about the low grade, or not low grade, but meningiomas, pituitary adenomas, those can tend to become malignant, or is it they just become invasive?
Pituitary tumors, I'm not aware of being malignant, but I don't really deal with pituitary tumors. It's really in the hands of the surgeons, sometimes the radiotherapist. Meningiomas, no question. They can be grade 1, which is classical. They can be grade 2, which is atypical. They can be grade 3 malignant. And meningiomas can be a challenge, no question about that.
And they're super common, right?
They're very common.
Yeah, I see lots of those.
Yeah. A lot of people with meningiomas out there. But we're starting to learn some molecular vulnerabilities of them. We also know that gross total resection does a lot to keep this from being a problem when it comes back. Or if you didn't get a gross total resection of like a grade 2, you'd use radiotherapy. But there are patients with meningiomas who need medical management, and there is very little in the way of medical management that can help meningiomas.
Maria Menounos just had her her meningioma removed. And in terms of malignant pituitary, do you consider craniopharyngiomas part of the pituitary group?
No, I think it's a separate tumor, far more common, obviously, in pediatrics, and there are certain of them that have molecular vulnerabilities, Achilles' heels, that people are starting to learn about with cranios. So, the genetics is beginning to help some tumors, but not all tumors, as we learn potential points of vulnerability for these tumors.
Now, is ionizing radiation for some tumor or some more benign tumors can change them to malignant, and therefore you want to use a proton beam? Is there any? I just am remembering. I think a friend that had a more aggressive pituitary tumor, and they told him they didn't want to use ionizing radiation.
There's a lot of reasons for that. The first reason is if you build a proton facility for $100 million, you better start using it.
Yeah, I've noticed that. I have noticed that, man. Do you guys have one? Is that
Loma Linda is the first one.
Yeah, they are doing it for extra.
We have a certificate of need request to get a proton facility, but it's not because of anything that it's more efficacious for primary brain tumors. People say, it's better for GBM. That's nonsense. What it's better for is the sense that there are certain tumors like chordomas where you really need to stop on a dime. You can't let the radiation go deeper because you're against some very, very vulnerable structures like spinal cord and things like that. There, the proton machine makes a lot of sense. There's also some data that's beginning to surface, although it's very immature, that says there's less toxicity associated with a proton approach rather than a regular IMRT. Nevertheless, we put a request in for one because there are patients who would benefit from that, from that kind of intervention. But I don't think that there's any proof that with a classical GBM it changes anything.
We spoke to Ben Williams, was that his name? He had a GBM, and he had all kinds of goofy ways of...
fascinating. 20 years of, melatonin, and...
He was doing all kinds of crazy stuff.
I am in his book. I am in his movie. I know all about Ben Williams.
And what are your thoughts?
What do you think?
What I think is that if you have a patient who wants to empower themselves and use things that are not in mainstream medicine, as long as those things don't hurt the patient, I think you should let a patient empower themselves and use whatever they want. And I was doing a bit more of that before we had better weapons, and I think that's why I wound up really talking to him on a regular basis and getting in his book. But I think that the way we approach it is, if you want to start taking a lot of the different supplements that are out there, we run it by our PharmD. If our PharmD says, look, I don't see any harm from this intervention, then we say go for it. If you're going to start using an intervention with a known toxicity, like when people were using Laetrile, which comes from apricot pits, with the risk of cyanide poisoning, I think it's a different story.
Well, or if you insist on obfuscating your primary treatment,
right,
on behalf of
no question about it. This is done in conjunction. People want to use anything as long as they're using it in conjunction with conventional therapy. I think that's the right way to go about it.
It's just super exciting. What I was going to say is, I don't know how to express this, but I remember when what convinced me to do medicine, I read The Citadel and I read Aerosmith by Sinclair Lewis.
I read that too.
And then reading books on the discovery of like yellow fever vaccine. I remember this thing I got out of the library.
You sound like me because you're talking about things like the microbe hunters.
Right.
Is a great book.
And
those are all things, but that's not why I became a doctor. So you go for first, and then I'll tell you how I became a doctor.
Okay. Well, I just remember going to the Hicksville Public Library in Long Island and getting some of these books and fascinated by how these people were able to grasp ways of changing diseases. And then it came to, I'm sure when you went into oncology, it was called pushing poisons and things where you really, and now what you're describing is so exciting. I was going to say, can you write a book?
It's personalized genomic medicine.
Right. It's a revolution, and I think it brings full circle to the old 100.
Weren't you with me talking about the prostate cancer?
Yes.
I mean, you hear this from all the oncologists.
Right. But if you could write a book describing your experience, because this is it's a seminal time in science, in medicine, where you're really making a difference, and the genomic level, it's like a rebirth.
Yeah,
so,
you're right,
and your story, I mean,
it's an exciting time to be. Now, on the other hand, two things. I became a doctor because of a show that aired when I think I was 9, called Dr. Kildare with Richard Chamberlain on Raymond Massey, and it was on for I think 5 or 6 seasons, and that's why I became a doctor, because I was so fascinated with that. That's what led me to read the books you're talking about. I'm the only one in my family who's ever become a doctor. And my kids, one, went to law school, one went to, they both went to Duke, one got an MBA in nonprofit. Nobody wanted to be a doctor except my wife and I. We'll go figure. But in any case, did you produce any doctors in your family?
No, I did not.
Yeah, I don't know. Maybe they see how hard we work. I don't know.
Well, that's right. My dad was, my uncle was, and my kids got a big load of all that. And we're in primary care and stuff. All of us were, and they sort of witnessed firsthand what happened to primary care, and how much misery there was in that, and they all went, something else.
My 95-year-old father called me this week. He said, I read a book by Max Brand, who is actually Frederick Faust, who invented Dr. Kildare. So,
wow, how interesting!
I got all episodes of that. I had to get it from a company that distributes from China, but I have every single episode on DVD of Dr. Kildare. And someday I'll watch it because that just riveted me all through my childhood.
And Dr. Kildare was just sort of, it became an acronym or a sort of what do we say, a shorthand for saying, a very good, aggressive, thoughtful doctor. Notice, Dr. Kildare or something?
Notice you're
Dr.
not
Kildare.
You're not referencing Marcus Welby.
Well, I was going to say, did he see?
I like that show, though.
Yeah.
I first learned about a couple of different diseases from Marcus Welby. I was in med school for Marcus Welby.
Well, let me tell you. You don't even know this. I will tell you a story.
You did tell me.
Oh, I told you.
Yeah.
Okay. Well, I took care of Robert Young for years myself.
Really?
And the doctor that he fashioned the character after was the doctor that preceded me taking care of him, who was still there when I was there. He just was like 75 years old, and became a very close friend of mine.
That's fascinating.
And the Marcus Welby character was indeed really the way this guy was, except he was an academic psychiatrist. He was not a general practitioner.
Marcus Welby. I love Dr. Kildare. I love most medical shows. If you haven't watched Code Black, you should watch Code Black. It's been on for 2 years. I think it's coming back for I think it's been on for 3 years, coming back for a 4th year. It's great because Code Black was exactly what was happening. If you read the stuff that came out about the Las Vegas hospitals, which went berserk after the massacre.
I want to do a reality show about training medical students. That's my new calling.
Well, if you want a guest lecturer, get me in there because I've got a mentoring program for female varsity athletes who want to go to med school. We put 100 into med school since 2005.
Very cool. Is there a website that you want to reference on that, or anything else you'd like people to know about you?
Well, I think if you look CAPE, Collegiate Athlete Pre-Medical Experience, you'll pick up something. We won't pick up much. We don't really website it very much because it's sort of a program unique to Duke. I mean, we give undergraduates the exposure they ultimately are taught to go in and do neurologics and histories alone. And most programs, like everybody with risk management says you can't let an undergrad in the room, much less let them do this stuff. But at our place, we follow all the rules. They learn HIPAA. They make sure they don't identify as a physician, but as a student. We ask first whether it's okay. And we got 100 kids in, and then more are going to continue to come in.
And your website for the Tisch Center is there?
Oh yeah, the Robert Tisch Brain Tumor Center will have everything. You just look at Preston Robert Tisch. Google Preston Robert Tisch Brain Tumor Center. You'll pick it all up. And then I could look up if you want the actual website.
That's okay. And do you have your own website you like to refer people to?
Oh yeah, that is a huge website. We have everything on there.
That's the Preston Robert Tisch Brain Center. Is there a Dr. Henry Friedman website or no?
No. Okay. I don't need that.
All right.
I'm one of the people listed there, but I don't have my own website.
Well, listen.
Hell, I go to work. I got a great picture of Sanjay Gupta and me. He's in his beautiful tailored. He's a good friend, but beautifully tailored Armani suit, and I'm in my blue jeans and my white hoodie, which is how I go to work.
Well, I got a picture of me and Dr. Drew, and I'm in my Vans, and he's looking like a star.
And Gupta's the surgeon. That's all. They get the
neurosurgeon.
The gravy. We all get the beans.
Yeah.
All right. Well, Dr. Friedman, it's such a privilege, and thank you so much for joining us here today. And
I'm honored. I wish my wife's not here. She'd be listening, but she'll listen yet.
Did you come out to LA at all?
Yeah, if you're out here, let us know.
Yeah,
we'd love to see it.
Drew has 1,000 podcasts and radio shows.
Yeah, right. Okay, fair enough.
Sounds good.
All right,
but anytime, sir, just let me know.
All right, you got Dr. Henry Friedman. Again, thank you so much, and we'll see you all next time. Well, one of the great parts about working in recovery is seeing former patients successfully move on. And I've had patients that have come up to me years later and shake my hand and say, sometimes people are kicked out of treatment. And many of these folks move on to become mental health professionals themselves. And, of course, the field of psychology is vast. The need for competent practitioners is huge. If you're considering this rewarding career, I urge you to consider the California School of Professional Psychology at Alliant University. Now, I've known them for a long time at Alliant University. I've spoken at their past events. It was founded in 1969. It's boasts an alumni network of nearly 50,000 people worldwide. And Alliant has fostered many of today's mental health pioneers, authors, and advocates. CSPP at Alliant University hosts both on-ground and online programs in business psychology, marriage and family therapy, clinical counseling. They also offer APA-accredited doctoral programs in clinical psychology that can allow for specialization in child psychology, clinical forensic psychology, and integrated psychology. And the faculty is crazy. It's made up of of leaders and historical figures like Abraham Maslow, Carl Rogers, Viktor Frankl, some of the true fathers of modern psychology. For more information, and I worked alongside of these students as well, by the way, in the clinical setting, as well as having lectured at the institution. So for more on the California School of Professional Psychology, CSPP, at Alliant, click the Alliant banner on our website or visit Alliant, ALLIANT.edu, alliant.edu.
Remember, you can find all these podcasts at drdrew.com. The Dr. Drew podcast, the This Live podcast with Dr. Drew and Bob Forrest, and the Adam and Drew podcast, which is available 5 days a week. Find them all on iTunes and rate us 5 stars. Subscribe and get it first. And if you're really happy, click on the Amazon banner at drdrew.com to help support the show. We'll thank you for it. If you join the email list via drdrew.com/contact, we'll send you a weekly infusion newsletter with Dr. Drew's news. We're so grateful when you get in touch. We read all your emails and we'll bring you the subject matter you want to hear about.
If you didn't know already, we have a YouTube channel. Go to YouTube/DRDREW, YouTube/Dr. Drew. See the live videos and podcasts there. Subscribe and you'll get it when we go live. Find the channel, get the videos today, but also be sure to download the podcast and listen to them as well. We appreciate your listenership. We appreciate your support. And we'll keep this thing going as long as you want us to.